Good afternoon, everyone, and welcome to our June ECHO session, where we will discuss and learn about community-level and family-based diabetes prevention. My name is Benita Rokiraj, and I serve as the ECHO lead for the Constellation Regional Collaborative. If this is your first time attending, please stay till the end to fill out our post-ECHO session survey to receive continuing education credit. Your attendance today and participation in our session survey at the end counts for the following continuing education credits: 1 AMA PRA Category 1 credit for physicians, 1 Certified in Public Health Recertification credit, 1 CHES MCHES credit, and 1 Community Health Worker credit by the South Carolina Community Health Worker Association. So successful completion of this activity includes making sure that you're registered on iEcho, attending the session in its entirety, and completing the survey. I just wanted to make a note that once you complete the survey, which we will share at the end, you will receive an email and certificate from the Southern Medical Association. That is for the AMA credential, but if you are looking to receive CPH, CHES, MCHES, or Community Health Worker credits, I ask that you please forward that confirmation email to me so that we can send you your appropriate certificate. Thank you again for joining us today. And let's take a quick look at the agenda to get us started. We'll begin with a quick round of introductions from my team, our panel, and attendees. We will have a didactic presentation by Katrina Brantley from Georgia CEAL and case presentation by Makala Smith from Prisma Health SE Mom. After the presentation, we'll open up the floor for questions and discussion. We really encourage everyone to participate at that time because the power of ECHO comes in through peer learning and sharing across disciplines. And towards the end, I will share details on our next session and the brief post-ECHO survey that helps us continue to improve and tailor these sessions to your needs. So as people trickle in, we'd love to hear about our attendees. So please take a moment to introduce yourself in the chat by sharing your name, employer or organization, and position and credentials. And as we get responses in the chat, I'd like my team to also introduce yourself. I think Maxine's on the call. Maxine, do you want to go first?
Hi, thank you, Benita. Welcome, everyone. My name is Maxine Arena. I'm the program manager for the Constellation Regional Collaborative. I'll pass it over to Agner.
Hi, everyone. Nice to see you all. Agner Munoz, Community Health Specialist for the CRC. I'm so glad to see all of you here. We have 32 participants, so this is great. Thanks for being here. And I will pass it to Sylvia.
Good afternoon, Sylvia Coleman. I'm a strategy consultant with the Constellation Regional Collaborative. It's great to be with you all this afternoon.
Thank you, team. And we also have Shannon and Sydney on our team who are traveling from conferences, site visits, all those sort of things. But, you know, this ECHO session wouldn't be possible without everyone's efforts. I'm very grateful for my team. And I'd like to introduce you to our ECHO series subject matter experts. I believe there are a few of us who've joined today's call. So Emily, would you like to go first and introduce yourself?
Hi, everyone. My name is Emily Ridley. I serve as a subject matter expert with the Constellation Regional Collaborative. I am a clinical pharmacist based out of an internal medicine residency clinic within Prisma Health in Columbia, South Carolina, where I serve primarily low-income urban population, but we see a lot of rural patients as well. So on a daily basis, I work with our patients in helping improve hypertension and diabetes control, work extensively with our quality improvement efforts across our system with regard to hypertension. Nice to be on today and listen to this talk. I'm looking forward to it.
Thanks, Emily. Dr. DePetty?
Oh, hello, everybody, and it's wonderful to be with you again, as always, and welcome to new members. My name is Don DePetty. I'm a physician, general internist, predominantly does primary care, but I also did specialized fellowship training after my internal medicine residency in Boston. in hypertension and vascular disease. I'm a senior consultant to the collaborative, as well as I'm on the board of directors of Constellation and the former chair of the foundation, the CCME Foundation. I'm at the University of South Carolina School of Medicine and Prisma Health here in Columbia, and it's just wonderful to be with you.
Thank you for joining us, Dr. DePetty, and for all your support with ECHO and our other program lines. Do we have anyone else on the call? I can't see who's on the call as I'm sharing my screens.
Dr. Bretler's on, I believe.
Oh, awesome. Dr. Bretler, would you be able to introduce yourself?
Sure, of course. Good afternoon, everyone. Jeff Bretler. I'm an internist and hypertension specialist from the Kaiser Permanente region in Southern California.
Dr. Bretler, your audio is very feeble.
I always have this problem. Can you hear me now? Are you able to hear me?
Very faintly, I think.
Well, I'll be very quick. Great to be here. I'm an internist and hypertension specialist from the Kaiser system in Southern California, where I help oversee the regional hypertension program there. And I'm also a consultant for the Hearts program with the Pan American Health Organization. Pleasure to be here.
Thank you. All right, I'd like to introduce our presenters and then have them take it away. So first, to introduce our didactic presenter of the day, we have Dr. Katrina Brantley, who serves as the project director for the Georgia Community Engaged Alliance. Dr. Brantley has over 20 years of experience as a public health practitioner, providing leadership and collaboration with representatives from both public and private sectors. And an alumnus of the Morehouse School of Medicine's MPH program, Dr. Brantley has spent the last 11 years working in local and state government, specifically at the Clayton County Board of Health in the cardiovascular disease prevention, and at the Georgia DrPH in maternal and child health. She earned her doctorate in public health leadership from Georgia Southern University, focusing her research on employee turnover and retention within Georgia's maternal and child home visiting workforce. With 12 years of experience in research administration, she has worked on projects related to cardiovascular disease prevention, youth violence prevention, and maternal child health. Dr. Brantley possesses extensive skills in overseeing financial records, community outreach, research projects, assessments, policy development, and developing strategies to achieve organizational goals and objectives. We're very grateful that you're here. And to introduce our case presenter of the day, we have Makala Smith, who is a registered dietitian and nationally credentialed diabetes care specialist, holding certifications of certified diabetes care and education specialist and board certified in advanced diabetes management. She earned both her bachelor and master's degrees in human nutrition from Winthrop University in South Carolina. Makala currently serves as grant programs manager in the OBGYN Research Department at Prisma Health Midlands, where she oversees operations for women's health-focused initiatives. Her work integrates clinical leadership, strategic planning, and stakeholder engagement to improve maternal health outcomes and promote sustainable care models. Prior to joining Prisma Health, Makala spent 9 years at Carolina Diabetes and Kidney Center in Sumter, South Carolina, where she directed ADA-accredited diabetes education and CDC-recognized prevention programs. Her contributions to diabetes care and education earned her the 2020 South Carolina Diabetes Educator of the Year Award. She currently serves on the Women in Diabetes Advisory Group with the American Diabetes Association and is the Secretary of the Diabetes Initiative of South Carolina. Oop, okay. I meant to stop sharing, but thank you both for joining us today. We'd like to begin with a didactic presentation, and Dr. Brantley, you can take it away.
Okay, thank you very much for that introduction. Let me share my screen. Are you able to see the screen?
Yes, but I think your audio is very faint, to me at least.
Uh-oh. Let's see. turn it up. Can you hear me now? Better? No?
I think a little better.
Well, I'll talk loud. Can you hear me?
Okay, yes, now we
Okay.
can.
All right, I'll just talk loud. Thank you. All right, let me close that. Well, thank you. So today we'll be talking about the lessons learned in addressing a family-based diabetes intervention that we're starting in Georgia for the Georgia CEAL program, and the role that our community coalition board played in this intervention. So the benefits, this program is a community engaged research project. And some of the benefits of community-based engaged research is that it addresses the differences in healthcare access and outcomes by making sure those strategies and interventions meet the needs of the people most affected by the topic being addressed. It helps to build trust in science by including both the people from the community as equal partners at the start all the way to the end of the research study, and it helps to improve health knowledge by working with trusted messengers to address the worries and fears within the community. So we do a lot of community engaged research at Morehouse School of Medicine. We definitely like to have the people who we are attending to work with be a part of the very beginning of the intervention, and so we're very excited about this work. And so Georgia CEAL, I do want to say, is a very long name. We use a lot of acronyms, but Georgia CEAL stands for Georgia Community Engaged Alliance, and the RESTORE stands for Reimagine Environments and Systems Together for Outcome through Research and Evaluation for Sustainability. And so in a nutshell, is basically we're trying to restore the environments and systems that work together to help reduce diabetes in the community and within the families. So this project is funded by the National Institute of Health, and I don't have any conflicts of interest to disclose. So I wanted to talk a little bit about our intervention and how it is set up. So the one thing that I want you to notice is that in the blue square is our Community Coalition Board. They are the center and the top of our intervention. We have about 23 members, a part of our Community Coalition Board, and they take on a major responsibility, which I'll talk a little bit more about some of the things that they have helped us with this intervention. And so our project is led by, we have multiple PIs that are a part of our program. We have 2 MPIs at Morehouse School of Medicine, Dr. Tabia Akintobi, Dr. Raquel Quarles, and we also have a partnership with Emory University as a part of our MPI, Dr. Mary Beth Weber, and we also have the health department as a part of our MPI group with DeKalb County Public Health, Dr. Sedessa Spivey. We have 2 arms in our intervention, one that is a family-based intervention and one that is a community-based intervention, and that's on the left and the right hand side. One we call our DPP, which is our Diabetes Prevention Intervention Partnership, and then on the other side is our Policy Advocacy Partnerships. We have a lot of people that make up our partnerships and are helping to guide our intervention and support us from the formative research into the actual intervention, and so we'll talk a little bit more about what their role has been in this intervention. But the overall goal is to really look at community social determinants of health and how can we support families and the community in understanding how to advocate for change, how to understand knowledge increases and change behavior, and looking at it in a research study. So NIH launched CEAL to improve the nationwide responses to a public health issue. When CEAL first came out, it was focused on COVID-19. But in 2023, the network expanded to add programs addressing other health concerns like maternal morbidity or other primary care interactions like diabetes. And many of the CEAL studies across the nation is doing various different types of study. Ours is focused on diabetes prevention. So looking at our theoretical framework that we are focused on in Georgia, we're conducting a pre-post study guided by the Consolidated Framework for Implementation. It is guiding our intervention, and we're also looking at it from a social ecological theory because we have multiple levels. We have a community level intervention, which is more or less that larger orange circle, looking at basic civic advocacy, education, mental health training of those community members. And a lot of those people are being trained in the same communities that we will be addressing our families or getting our families from. The green level is on that interpersonal because this is a family-based intervention. We are wanting to have a parent, male or female, who has the prediabetes, but also inviting their child to come to the intervention who are between the ages of 12 and 17 to learn about prediabetes prevention and to hopefully make some family changes at an early age before. And so the lower level, the blue one, is where we're focusing on that, the parent who is our primary focus, but also bringing that child in as well. So we understand that there is a lot of factors that can facilitate or hinder access, interpersonal skills, organizational skills, policies. So we're looking across the levels to really try to impact the social determinants as it relates to reducing diabetes prevention at a community level and family level. So digging a little closer into what our actual intervention kind of looks like, the dotted line kind of says that there's a relation, but it's maybe not necessarily. Like, for example, for the community level in the orange, some of the people who may be trained in the community may not be an actual family member. They could if they have the criteria for being pre-diabetic and they have a child between the ages of 12 and 17. But there is a possible relationship if that community member may have maybe a program that helps with food insecurity or help with exercise in the communities that those families are coming from. So there is a possibility that there is some influence there. Moving over to the yellow is really where that family intervention kind of picks up, where we're looking at family cohesion and how does the relationship between the parent and the child change. Does it increase education? Do they have more communication about diabetes between the family? Things of that nature is what we are looking at that yellow level. The green is some of our outcomes. We will be looking at the knowledge increase for both the parent and the child. Any behavior changes around physical activity, exercise, nutrition changes, and any habits. And so our outcomes, which is in the blue, for the parent, we are focused on weight reduction. We're focused on their weight. We will be taking the weight of the children, but we're not focused on the weight for the children. In our intervention, the parent is the one that would have risk factors for prediabetes or may actually have prediabetes. So we will be taking the weight of the parent weekly, but we'll also take the weight of the children at the beginning of the intervention, at the end of the intervention, and 3 months after the end of the intervention. We'll also be looking at some cardiometabolic outcomes. So we'll be taking some just finger stick lab testing. We will be looking at their cholesterol, overall cholesterol total, and triglycerides, looking at BMI, so height, weight, waist circumference. We'll be looking at their weight, like I mentioned, blood pressure, and their A1C and their glucose. So those are some of the cardiometabolic changes that we'll be looking at pre, post, and 3-month follow-up for each of our cohorts. So our overall goal for our intervention is to reduce type 2 diabetes risk among Black and Hispanic parents and their children, and that is their individual and interpersonal levels. We're hoping to support mental health in the community through mental health training. So for our individual family-based intervention, we are increasing the mental health training within that. We have a partnership with Georgia State who will be helping us to integrate more mental health challenges and support and trainings to the families, as well as we're providing mental health training for the community. And then the third major goal is to positively advance community level diabetes prevention and other health issues through community research, capacity building, mobilization by training community leaders in mental health, identify mental health challenges within the community, connecting them to resources of how to connect people to those resources, as well as civic advocacy training and just basic learning. Who do you call? What is your elevator speech when you have an opportunity to meet someone to talk about what is your next steps and how do you advocate for change in your community? And so this goal was created by our Community Coalition Board. We did a community health needs assessment in 2022, and at that time, from the community needs assessment, diabetes was the topic that came out that we need to focus on, and that they said that we should focus on it from a family perspective. And a lot of the reason why is because we're trying to stop generational diabetes, and a lot of times the habits and the behaviors of the child is what, well, from the parent, it goes over to the child, because a lot of the behaviors, the foods that they eat is very similar. And a lot of times it's easier, many times we make changes for our children that we may not make for ourselves. And so if the child is involved in the change and they understand the reason why we should eat more baked chicken and not fried, or why we should move more, then maybe they will not only support their parents in those changes, but they may join their parents in those changes. And so those are some of the reasons why it came up that we should focus on families and bringing both a child and the parents and the entire family actually to those intervention sessions so that they can hopefully make family changes that can reduce generational diabetes. So this is a picture of one of the many pictures that we've taken of our Community Coalition Board meetings. We have meetings every month. Once a month for about an hour and a half with our Community Coalition Board, but once a quarter we have a face-to-face meeting. And one thing I wanted to point out from this picture is that we have both a face-to-face and an online version, so people can join us from wherever. Our project is going to be focused in 4 counties in Georgia. It is in Fulton, DeKalb County, Houston, and Bibb County. And so we know that we have partners in Bibb, which is about an hour away from Atlanta. So many times they can't come to a face-to-face meeting, but we want to give them an opportunity to be able to be engaged and join. So you see some people that are online joining us in this picture. But some of the role that our Community Coalition Board plays is they help to govern and co-create all of the intervention, from the planning, from the implementation, evaluation strategies. They have looked at our focus group guides. They have helped approve data collection tools. They collaborated with marketing it through their networks of people, with promotion, looking at our social media campaigns and making sure that we are meeting the communication needs of the population, and that we're saying things that are culturally correct and would that the coalition is really helping to support us in this intervention and so forth. And then many of them have partnerships that Morehouse may not know about, that they can help us to promote the programs and things of that nature. So that has been a major support in our coalition board. So this is a list of our coalition board. We are always looking to see who is missing from the table and who should we include. CEALs across the nation, there's about 21 different CEALs that are across the nation who have more than 1,000 organizations that are part of our coalition board, but we have about 23 members are part of our coalition board. And from this list, you can see we have WellStar, which is a huge medical organization in the Atlanta and other areas. We have Mercer University, Georgia Tech. University of Georgia has supported us with things. They're not a part of our coalition, but Georgia State, Georgia Tech, Mercer University, we have multiple health departments that is supporting us in our coalition. We have Fulton County, DeKalb County, Macon, Bibb County. So all of the major counties that we're wanting to support in this intervention, they are a part of our coalition board. We have a lot of academic, organizational, faith-based, nonprofits, community-based organizations that are part of our coalition board, and they really help to steer our intervention and give us, really guided structure to this intervention before we even launch and so forth. And then also wanted you to see that we also utilize the National Institute for Minority Health and Health Disparities framework. As we look at the social ecological model, we wanted to look at it from the individual, the interpersonal, and the community. And because we're focused on social determinants, we wanted to use these domains of influence are really in line with social determinants, the biological, behavior changes, the built environment, healthcare systems. And we took a chance to really kind of dig through how does diabetes intertwine between each of these levels. And so you'll get a chance to look at it in more detail. I'll send this PowerPoint after this presentation so that you can really dig in to kind of see how we looked at each of these levels of influence and how our program can at least review or connect to these levels of influence and how we are considering those levels when it comes to diabetes prevention for the family and the community. So our actual research question we have approximately is 5. So we have a 1A and a 1B. So I mentioned before, we're using the consolidated framework for implementation. So we wanted to know, does this framework help guide the trainings that we're providing? Like we use those different domains within CFR to guide this formative research before we even started doing the intervention. So we use this guide to really understand the adoption, the changes as it relates to the community level training and the family base. So we wanted to determine if there is improvement in adoption or change when we look at those different levels. We also are just generally looking to see, is the family diabetes intervention improving those health outcomes? So we're looking at the cardiometabolic changes. Are people losing weight? Are they staying engaged? Are they coming to the sessions and so forth? So we'll be looking at those type of intervention effectiveness. And then what are some of the challenges to implementing a family-based intervention, which is definitely different. Most diabetes prevention, we're using the Centers for Disease Control, DPP, Diabetes Prevention Intervention, which is a year-long program. But our community coalition board said that that's too long for families to have a child involved in a program that is that long. And so on a basics, most of it, you should do the first 16, but when we did our formative research, a lot of the families said 16 weeks is too long as well. So our intervention is going to be 12 weeks, and we'll see if we can keep families engaged for 3 months. And does it make a difference as far as their cardiometabolic changes, and will they lose weight? Will they pick up more habits? Will there be more interpersonal connection between the parent and the child? And so the last question 4 is looking at those community trainings that we are we're doing in all the counties to see if any of what we're calling them community health ambassadors, are there any changes that they did in the community that can impact diabetes prevention at the community level. All right, so we're getting to the good stuff. What was our lessons learned for our formative research, which we completed? We did about 6 focus groups. Many of them were stakeholders. We did both stakeholder focus groups and families. We had families, the child and the parent. They were in separate rooms, and we asked questions to both the parent, and we did have stakeholders that are in those counties that can kind of speak to, you know, physical activity challenges, nutrition challenges, or any. We presented this intervention that we were planning to present and got their feedback on what should we do, or how should we interact, how do we reach families, how do we promote it, what should we say. And so this is some of the feedback that we received. And so even though we're focused on a diabetes prevention, a lot of what we learn, I think, can cut across any cardiovascular intervention that you're considering doing with families. If you're thinking about a cholesterol reduction program, or just a lessons that we learned in our formative research, I think that you can really look at as something that you might want to consider if you are considering a program yourself. So some of the overarching themes that came out of our focus groups is that they're motivated, but they're constrained. Many of them talked about that the families have, they have deep-rooted health concern about the health, but they are facing real barriers to being able to be a part of an intervention, regardless of whether it's just how do you find more time in a day to be able to do all you need to do as a parent. But the logistics of coming to a training for 12 straight weeks is a lot, or 16 weeks, or even a year is a lot. There is health. Their health is important as a lived experience. They are grounded in their family history and their generational patterns. Many of the people who came to our focus groups have dealt with diabetes in their family. Their parents or grandparents may have had experiences with diabetes. There have been people come to our focus groups who have lost family members, even their spouse, to diabetes. So they have a real reason to be there, and they're grounded in that family history. They're really wanting to stop generational diabetes. So that's education is very important to them. So a lot of people talked about the flexibility of a program is very important. They needed something that's not a rigid schedule. But whatever program needs to really understand that these participants have real lives. They have a lot going on. Many of them, you're talking about bringing in children. A lot of them talked about their kids are very busy. They're playing sports. They're in debate clubs, and a lot of these things happen after hours, so the time is a big structure, a big challenge. It needs to be practical over theoretical, because I know from a research perspective we come with the theories and things of that nature, but they talked about that families want real skills and tools that they can use today. Not just changing my diet, but how are you going to help them with the realities of a busy schedule. So when we talked about cooking demonstrations, which we talked about doing in our intervention, that was exciting to them, because a lot of times our families in our focus groups talked about, how can I make meals fast? How can I make meals healthy that my child will eat as well? Because a lot of times children may have a more limited palate of what they want to eat. So how can you, make Brussels sprouts entertaining enough that my child will want to eat them, and so forth. So, and then they wanted to be a part of the co-design. They want to be heard when it comes to this program development and feedback in real time. So, if there's a question that they have, how will we be addressing their needs as we go within this intervention? And so that's why we were wrapping around this program is going to be done by a community health worker model. So those community health workers will be able to connect them to other needs and supports as needed in this intervention. So when it comes to motivation for participation, and I kind of talked about it, it's really driven by their family history. They are also interested in breaking generational diabetes. They mentioned incentives is a great support, but kind of what came out is that incentives should be looked at as a resource and not just a reward. So if you're giving a gift card, that this is a resource to provide more support in your family to buy healthy meals, or how can you show them where they can take the gift card to get more for their money. Maybe a partnership with a family garden or something like that, where they can go and get more money, get more produce for their time. And so other things like things that they talked about would be good is, a lot of families don't have a scale at home. So, maybe giving a scale or something like measuring cups or things of that nature. And so the children said that they do not want this to feel like going back to school. So they want it to be fun and engaging, excited. They were definitely excited about the cooking demonstrations. And the parents said that it needs to be realistic, affordable, and really kind of focus on meal strategies and how do they get more in the little time that they have to do with their families. So some of the barriers that came up to participation was the program link. That is a challenge because parents are very, very busy, and that changes over time. And they have a lot of competing schedules, a lot of demands on their little time, and then a lot of our participants don't just have the one child between the ages of 12 and 17. They may have multiple kids. So then what are they going to do with their 3-year-old? Or they may have multiple places that they have to go with multiple children. Like one child may have to go to band practice where the other one has to go to basketball practice. And so this program needs to be a little bit flexible. So think about flexibility, because a lot of families are feeling overloaded. They have sometimes low energy after really pushing and doing all that they have to do. And many of them are doing this while working a full-time job. So you have to really think about shorter sessions, flexible timing, and possibly a hybrid program if possible. So overall suggestions for the program is that you really want to promote family engagement, making things fun, especially when you have the kids. It needs to have not as much structure like going to school again for them to be engaged. You want to have a flexible movement. So our intervention will the first few minutes of it will engage maybe walking together or doing line dancing or something to get them moving. You want to engage your parents as partners, so provide tools to support children's activities, equip parents as trusted messengers of those healthy behaviors. So, trying to open the dialogue between parents, because a lot of times when parents are dealing with whatever chronic disease or potential chronic disease, they may not share as much with their children, but this is a way to bring both that child and parent together to engage. And so promote family integration and build activities and so forth. So the last two slides. So once again, I mentioned again that our Community Coalition Board really took part in the design, the translation of our research, the outreach, the communication. They've helped with identifying food resources, physical activity resources in the community, talked about communications styles and how do we communicate with our parents. They've reviewed all of our support material, focus groups and things of that nature, and they have been instrumental in getting this intervention. So that was our formative. We just recently got our full IRB approval, and we're starting to do enrollment to get our intervention started in the next couple of weeks, actually. So I'm very excited. Thank you.
Thank you, Dr. Brantley. That was very informative, and I'm sure a lot of us have questions. I'd ask participants to start putting in questions in the chat if you have any, but we will now move on to the case presentation by Makala.
I should have unmuted first. Made it more complicated for myself. All right. Can you guys see my slides right now or no?
You were sharing, but not anymore.
Oh.
Yes, now we can see it.
Being slow. Hang tight. Okay, can you see them okay? Or is it like a weird screen?
We can see the slides, but it's not on presenter mode.
Okay. I'm gonna exit out of this one. How about now?
I can't see your slides anymore. Would you like me to share on your behalf? Would that be
Let's
better?
do that. Let's
Okay.
do it.
Okay.
While she's pulling them up, Katrina, that was great. I really enjoyed it. And I love DPP. I have a big heart for DPP, and I'm starting a RCT with a like DPP-esque model for postpartum hypertension management. And would love to chat more. That was awesome.
Oh, absolutely.
All right. But what I guess I'm here to talk about is the SC Moms program. So I'll do that. We can go to next slide. So these are some of our collaborating partners. I'm going to go over this really briefly, but we are funded by the Blue Cross Blue Shield South Carolina Foundation through a collaborative partnership with Diabetes Free SC. And our Midlands site specifically has additional funding from the Center for Rural and Primary Health Care. And on the right, you can see that it takes a good many partners to make this work come to fruition. Next slide. So SC Moms is an initiative designed to improve outcomes for pregnant women with all types of diabetes and pregnancy through a coordinated patient-centered model of care. We launched in 2020 and have expanded a few times, but most significantly in 2025. And I'll go over some of that. But South SC Moms aims to address the complex challenges of diabetes and pregnancy through a multidisciplinary approach. And to date, we've served a little over 3,500 women with diabetes and pregnancy. Next slide. All right, so we are South Carolina based at the moment. I come from the Midlands site, but we have two additional what we would call hub sites in the upstate of South Carolina. So the Midlands and upstate sites are both through Prisma Health. And then our Low Country site is based out of MUSC. So all of our programs are a little bit distinct, but we collaborate together with common core values and team members, and we share a statewide data repository for the collection of data on these participants. Like I mentioned before, we're a team-based approach, so it looks a little bit different in each place, but we're a combination of maternal fetal medicine, endocrinology, community health workers. Our site uses a lot of nurse navigators and community health workers to deliver care, diabetes educators, dietitians, social work, and education being a core value of the program. Next slide. So we talked a little bit about some of these key components. One I didn't mention yet, and I should have, but we do have on our team, it's a dedicated referral specialist, but I think those of us that work in diabetes day in and day out know the challenges that come with the frequent need for prior authorizations for access to diabetes technology or insulins or concentrated insulins or any number of those kinds of things. We also face a lot of barriers with even getting like necessary additional testing for our patients, like maternal echocardiograms and things like that. And so having this dedicated point person to help with those authorizations has been a game changer for us. Some additional wraparound services that we provide. So we really do aim to be a one-stop shop, but we do social determinants of health screening and mental health screenings on all of our patients. Those who it makes sense for, we do retinal screenings in office. So these are done on site with a little iris camera, and then they're read by an ophthalmologist off-site. We do a lot of education and obtaining of personal continuous glucose monitors for patients. A lot of our program takes place through remote glucose monitoring. We try to offset appointments as much as we can unless they're needing to come in for an ultrasound or testing or something like that. We do insulin pump training and adjustment for those who need that, and then also provide some wraparound food access support through Food Share South Carolina. So that's a pretty sizable box of produce that feeds a family of 4 their fruits and veggies for about a 10-day period of time. It's a 20-pound box of produce. So we're able to distribute those to our patients twice a month. Next slide. So our overarching aims, we want to provide that one-stop shop care, kind of like Katrina was talking about. These folks are busy, they have limited bandwidth. So as much as we can provide everything from a singular visit as we can, we try to do that. We want to improve glycemic control, which we hope decreases maternal and fetal complications and reduces triage and ER visits. Our other initial goals were to expand telehealth through remote patient monitoring, which is much easier in modern day than when we were thinking about this project in 2019. Address social drivers of health, improve diabetes knowledge and skills, increase access to diabetes medication and supplies, and adopt use of diabetes technology as it makes sense and is desired. Next slide. So these are a little bit of data on these moms. You can see here, this is data on a little over 3,200 of them. You can see about 10% of our patients have type 1 diabetes, about 28% have type 2, and then the rest have some spectrum of gestational diabetes, either diet controlled or insulin controlled. The majority of our patients have Medicaid or are uninsured. And the majority of our patients are women of color and are English speaking. You can see our teams are doing an average of about 250 blood sugar reviews a week. We have done over 600 retinal screenings. We're working to improve enrollment in our postpartum program that we have through the year postpartum. We've helped with over 600 rides to appointments, over 1,000 hygiene bags. We have a hygiene pantry in our clinic where patients can shop for items that might be helpful for their family in their home, things like toothbrushes, toothpaste, feminine hygiene products, deodorant, soap, those kinds of things. Over 4,500 mental health screenings, over 4,000 food share boxes, over 5,000 CGM placements in clinic, and we're probably at this point close to 50,000 encounters. Next slide. And this one has some little prompts, so if you'll go ahead and you can go ahead and click them. There are like 2 more, I think. There we go. So this slide right here looks at some of our moms' data against a comparator group of women in South Carolina who were not a part of the MOMS program at the time. I will say that these, are a little hard to suss out because this early data was taking place during early COVID. But we can see with MOMS patients, we had a significant reduction in number of C-sections, significantly less NICU admissions, less NICU length of stay, lower preterm birth rate, improved APGAR scores, and we had fewer babies that were large for gestational age and fewer babies that were growth restricted. We can go to the next slide. What do the patients think of it though? So that's important too. I think the overarching, when I take this patient satisfaction data and plug it into ChatGPT, it comes out with a lady that says she feels supported and has all these things around her. But the most important things for us is for patients to feel like their care is accessible, that it's not overly burdensome, that they feel listened to and safe. That way they feel like their team is on one accord. I think that's been one of the most impactful things as a member of this care team is working together all at one time to come up with a patient's care plan instead of it being rather disjointed in different places at different times. Next slide. This is a little snapshot of our Midlands site more specifically. So in 2020, we started with our first site in Sumter, South Carolina. And then in 2023, we expanded back to Columbia, which is what we would consider our home base. Most of us that work on the mom's team live in Columbia. And that's where our resident clinic is housed, as well as our maternal fetal medicine division. So we have little pocket clinics in MFM in our resident clinic, and have been able to incorporate our residents into this care model. And then just this year, this February, we opened an additional site in Orangeburg, South Carolina. So our little offshoots in Sumter and Orangeburg. In Sumter, we're there once a week doing ultrasound and team-based care visits. In Orangeburg right now, we're there twice a month, but we'll soon be adding a third day a month. And then in 2027, we are aiming to open a next site in Aiken, with the goal being to saturate our perinatal region. We can go to the next slide. These are just some feel-good pictures of us opening our Orangeburg site recently. This is a real labor of love. Orangeburg, South Carolina, if anybody's familiar, has one of the highest maternal vulnerability index scores in our state. There's real lack of access to care here. This is the first time there's been maternal fetal medicine access in Orangeburg, where patients aren't having to drive over an hour to an appointment, and they can get their ultrasound and testing out there too. It's been very rewarding and exciting to see how people feel about having care where they live. They said, we never thought we would have something like this where we live, that Orangeburg would have something so nice. So it's been great. And then as we look forward, right, kind of to Katrina's point, we want this generational legacy care for women with diabetes and pregnancy. Pregnancy is this unique and exciting opportunity to impact a mom and her baby and her household. The hand that rocks the cradle rules the world. And so if we can help equip and empower mom during this stage of her life to learn habits, taking care of herself, what it means to have diabetes, and impact her fetus. We know a lot about fetal programming and how exposure to hyperglycemia in pregnancy impacts how that baby grows even from the earliest days, but also to other kids at home or what life looks like in the house. So we know that better coordination of care postpartum and preconception is a piece of that too. And this is we've done a pilot project with this, and we'll be scaling preconception and postpartum care to the Midlands area in the next 2 years. I think we're about out of time. I had a patient, and we can not do it if we don't want to, or we can quickly skim through it. Up to you, Benita.
Okay, sorry, I was trying to figure it out. If we can like quickly skim through it so that we have like a couple minutes for questions.
Yeah, I'll do 1 minute. So this is just an example of a patient with type 1 diabetes coming to us. She was admitted to the hospital with DKA very early in her pregnancy, and they sent the consult to moms from the hospital. You can go to the next slide. And just to show kind of a picture, these are some of these things we look at. So at the time, she was a type 1 without a continuous glucose monitor or an insulin pump to manage her diabetes. She did have vials of insulin that she was using. It was insulin that she was able to buy over the counter at Walmart. So not an ideal profile for type 1. She had not had a recent eye exam, baseline lab work, diabetes education, depression screening, social determinants of health, and at the time she did not have health insurance. We can go to the next slide. She was diagnosed at 17, and at the time we got her had had diabetes for about 11 years, and this was her 4th pregnancy at the time. And she had had a preeclampsia with both of her previous boys, who were both over 10 pounds at birth. She had never been on an insulin pump before, and was taking MDI. We can go next. We can skip that one. The gist was she wasn't eating that well at the time. Her depression screening was negative. She was a non-smoker. She was living with her husband and 2 kids. They had just moved from out of state. She had been uninsured between pregnancies when she did not qualify for Medicaid. And we can see her regimen after discharge. Next slide. She had a lot going on. A1C was 11.7. She had a little bit of protein spill in her urine, which made sense with the history of past preeclampsia and type 1 diabetes. And we did antibody test her because we had unknown past medical history, which did confirm the diagnosis of type 1 diabetes. We can go to the next slide. And so after her mom's consult, we got access to some of these services in the first trimester and got our checklist rolling. We can keep going. And then we can see some of her timeline. So this looks at first trimester and all the things that we kind of needed to rapidly accomplish. Education, our community health worker helped her get signed up for Medicaid and WIC in our area. She was able to then get an insulin pump and her own CGM. We were giving her CGM in the meantime until she was able to get it. And we can see these blood sugars start to come down. By around 10 weeks, her average was 180. By 12 weeks, 169. A1C down to 9.3 from 11.7 in 4 weeks. Keep going. And skip that one. We can see she's able to get on her insulin pump, and we see this blood sugar average like quickly improve. So we see it go from 169 to an average of 135 by 24 weeks. She got her fetal echo around that time and anatomy around 20 weeks. And A1C comes down to 7.1. And then you can just skip to the last one and people can look at it while we talk. Great news. Her previous babies have been born around 34 weeks. This baby made it to 37.0, which is the goal. For type 1 diabetes, this baby was over a pound less than her previous babies. And it was the first time she got to have a baby go home with her that didn't stay in the NICU. So that felt like a big win to her to have a normal hospital experience. Thanks, guys.
Thank you so much.